What I'd like to do is to put the issue of structural racism in context. Can you see my slide? Yeah, there we go. The opening line of my book, The Health Gap, was why treat people and send them back to the conditions that made them sick. I'm not primarily going to be talking about the health care system, rather the conditions that make people sick, the social determinants of health. If we look at the evidence on what causes health inequalities, this comes from my two reviews, the 2010 Marmot Review, Fair Society, Healthy Lives, and the review that I published 10 years later, Health Equity in England, the Marmot Review 10 years on. And we have what's now become known as the 8 Marmot Principles. Give every child the best start in life, education and lifelong learning, employment and working conditions. Number 4, pretty radical for a rich country. People should be able to afford to eat, pay the rent, feed their children. Number 5, healthy and sustainable places in which to live and work. And number 6, taking a social determinants approach to prevention. We've added 2, tackle racism, discrimination, and their outcomes, and pursue environmental sustainability and health equity together. And as I said, I want to put the issue of racism in context. I'll show you one slide of what's happened to health nationally. Essentially, what's happened is life expectancy stopped improving around 2010. And what I've got here is 2 regions, London and the Northeast. And people are classified by where they live, classified by level of deprivation. And what you can see is the more deprived the area, the shorter the life expectancy. Now look at the least deprived 10%. The differences between London and the Northeast are small. If you're rich, it doesn't much matter where you live. Now follow deprivation. The greater the deprivation, the greater the disadvantage of living in the Northeast compared with London. The social gradient is steeper in the Northeast, or to put it a different way, both if you're deprived, it's worse being in the Northeast. If you're in the Northeast, it's worse if you're deprived for your health. And if you can see what happened over time, in London, life expectancy improved across the gradient. In the Northeast, life expectancy fell in the poorest 10%. It didn't rise in the next 10%, or the next, or the next, or the next. It didn't rise in the bottom 60%. So where we were pre-pandemic was that life expectancy had stopped improving, inequalities had got bigger, and life expectancy for the poorest people had got worse. Then came the pandemic and made that all worse. In my 2010 review, I coined the rather awkward phrase, proportionate universalism. I was trying to combine 2 ideas, a Nordic approach of universalist social policies and a more typically British approach of targeting, means-tested benefits. So I said, what we need is effort proportionate to need. If, as you look to the right of that slide, you've got less deprivation, higher income, and better health. And to the left, you've got more deprivation, lower income, and worse health. If you intervene only on the worst off, you miss that health disadvantage. of people who are above that threshold of intervention, but still have worse health than those above them in the hierarchy. So I said, what we want is universalist policies with effort proportionate to need. What did we get in Britain post 2010? We plotted life expectancy for every local authority in England, 2010-12, and the subsequent reduction in local government spending up to 2020. And what you can see is the shorter the life expectancy in 2010-12, the steeper the subsequent reduction in local government spending power. This is effort inversely proportionate to need. The shorter the life expectancy, the greater the need. The greater the need, the greater the reduction in spending. Could this have played a role in the slowdown in health improvement, the increase in inequalities, the decline in life expectancy in poorest areas? Yeah, I think it could. Social justice requires we take urgent action on the evils of racism. So I've given you the context, and we said that racism can impact on health in potentially three ways. Racism, direct impact of racism. It's bad for mental and physical health. Second, racism conditions exposure to the social determinants of health. And third, it has impact on services. If we look at child poverty, defined as living in a household at less than 60% median income, the UK had the steepest rise in child poverty of 38 countries, predominantly rich countries. Deprivation, doing without two or more of six basics, the six basics being housing, heat, light, food, clothing, and toiletries. 1 million children living in a state of destitution, a 2.5-fold increase in 5 years. And it relates to your ethnic group. You can see marked ethnic differences in child poverty. Interestingly, when we look at performance at school, children eligible for free school meals do worse than children not eligible for free school meals at Key Stage 2 for every ethnic group. But look, for example, at the Bangladeshi kids. The difference between the free school meals children, the poorer children, and the average is quite small. Look at the white British. The white British kids in relatively poor families are doing much worse than most ethnic groups. So if you had a view that somehow being from a deprived ethnic group is bad for performance, well, yeah, but the poor white kids are doing worse. But then if we move on, and look at what happens in the workplace, median pay per hour. Oh, the Bangladeshi, Pakistani, Black Caribbean are doing much worse. In other words, what's going on here is that discrimination is kicking in the workplace. The kids are doing okay in school from the different ethnic groups, but it's kicking in the workplace. now's the time to wake up to the scale of this inequality and remove the scourge of racism. Are we doing anything about it? Well, yeah, we are a bit. There is ethnic inequality in services, which of course are a real issue. And we see maternal mortality particularly high in minoritized ethnic groups. Infant mortality, which should be low everywhere, is showing predilection for certain ethnic groups. Mental illness, again, showing ethnic differences. One of the things we've been doing in the UK, initially not focusing on racism, but now it's included in the work, is working with local areas. We now have getting on for 50 local Marmot places. The first was Coventry, declared itself a Marmot city, Greater Manchester, Cheshire and Merseyside. In England, Wales, Scotland, we've got these Marmot places working on my 8 principles of action, including tackling racism, and putting them into place locally. During the previous government, and I hasten to add that I maintain the fiction that I'm not party political, but what was happening nationally with austerity is it was making everything worse. When Keir Starmer, as leader of the opposition, launched his health mission, they had a technical appendix, and it said the next Labour government will amplify the approach of Marmot cities like Greater Manchester and Coventry by making England a Marmot country. That's encouraging. We're working with Scotland to make Scotland a Marmot country. We hope to do that with Wales. We'd like to do it with England too. And it's that that makes me hopeful. There's enough to make one pessimistic and despairing going on in the world at the moment. To quote Raymond Williams, to be truly radical is to make hope possible rather than despair convincing. Thank you.
Thank you, Sir Michael.